slides, my disclosures. Okay, so Dr. Kovacs did an excellent talk earlier, just a little while ago, on laser, and so I'll be kind of continuing on from there. So nitinol stents are being used more and more commonly in the therapy of SFA, popliteal, and infrapopliteal disease, as multiple reports have shown improved patency and better symptomatic relief as compared to just plain old balloon angioplasty. And this is crucial when you have a flow-limiting dissection. In-stent restenosis is common over time, unfortunately. Interventional therapy of ISR has historically been associated with high restenosis rates and its complications. Restenosis is usually secondary to intimal growth in a fully expanded stent, where occlusion has a superimposed thrombus, hence the reason a filter is always a good thing to do. Several investigators have noted increased incidence when stent fractures are present. Historically, treatment of long diffuse and occlusions showed very poor patency, and one study of less than 20% at 3 months with a high embolization rate. So POBA for ISR in general, this is back in 2005, in which they did an IVUS 30 minutes post-POBA. This actually showed these results on intravascular ultrasound suggested compression and decompression as the main results for early lumen loss after dilation of in-stent restenotic lesions. The rationale, suboptimal results with balloon angioplasty are common. Angioplasty dilatation of intimal hyperplasia compresses the aqueous extracellular matrix, however, hydration ensues. The thrombotic material may embolize and is very thrombogenic, including the distal vessels. And of course, the elastic recoil is also there. Suboptimal results with repeat bare metal stenting is not a good idea. Embolization is always there. There's no barrier to actual intimal growth and won't seal any pseudoaneurysms. Lumen's compromised by the multiple layers of stents, so you get narrowing from there. Mechanical stabilization of fractured stents with either covered stents or nitinol stents is probably going to be crucial. 3 FDA approved therapies, which we've gone over here, alone or in conjunction include the laser, the Vibond stent, or the DCB. So wherever you want to know this, the TSACA classification 1 through 3, and there varies 2-year restenosis rate, with 3 being the worst. So I excite ISR with Dr. Dibble, Craig Balker, a couple of the other esteemed panel right here. So I won't go over this because Dr. Kovacs just given us in great detail, so we're just going to skip on. The baseline lesion characteristics are core lab educated data in which the laser and angioplasty showed the calcium with 1 vessel runoff and stent fractures being the predomination. The longest lesions in any IDE peripheral study, and then 20% of lesions were greater than 30%. So laser atherectomy is superior to angioplasty alone for the treatment of ISR. As you can see, similar in lesion length, calcium's more along the lines of the lasers group, and going from there. However, the primary endpoints, as you can see, from freedom from major adverse events and freedom from TLR, are definitely different and statistically significant. As mentioned before, freedom from TLR, there's a survivable probability with increased mortality down the line. Eczema laser is comparable to the PTA, which also the freedom from MA or major adverse events is also similar too. The lesion length in TNLAR, as all said, from 5 millimeters or 5 centimeters to 35 centimeters, all show favor along the lines of laser along with angioplasty. So in conclusion to the Excite ISR, laser plus angioplasty is superior to angioplasty alone. First FDA approved controlled study demonstrating the benefits of laser. As Dr. Sharma said earlier, it'd be nice to see what the jet stream can do in this realm too. And the laser PTA is also an atherectomy device that FDA indicated for femoral popliteal ISR. So now, adding a little bit of a mix to it, the DCB, laser plus DCB versus DCB alone. All diabetic CLI and total occlusions is a randomized controlled trial with laser and DCB with 24 patients versus the DCB side, which is also 24. Treated length and lesion length are greater than 20 centimeters, 100% crossing success, and the complications are listed there. So 12 months data, laser plus these had much better outcomes, as you can see, from patency, from freedom from major adverse events, from limb salvage to freedom from TLR also. So final case I'm going to go over here. It's a 66-year-old Rutherford. It's a complete in-stent restenosis, Tasaka 2 down to 3 from the level of the adductor canal, where reconstitution at infrapopliteal with a pretty decent runoff. So crossed it with knuckling a wire and a quick cross. The quick cross catheter was then placed distally just to make sure we're intraluminal. The DSA image is on the right-hand side, so pretty decent 3-vessel runoff, an osteal lesion down there. Here comes the laser. You've also seen it before, as Dr. Kovacs mentioned, slow and steady wins the race, 1 millimeter per second. You're not trying to dot the lesion, you're actually trying to create a channel of ablative force from the laser. This is a 2.3 laser. It was a 7 French up and over system. The 6 French is compatible with a 2.0 turbo. This is after angioplasty or just regular angioplasty. After the laser, pretty good result. Finally, here comes the DCB, 2 overlapping DCBs, and here's the final results. So pretty good, with 3 vessel preserved on the way down to the foot. So in conclusion, it's a new paradigm emerging for the treatment of FemPop ISR, but the new data is coming out, as Dr. Shamas had mentioned earlier. The angioplasty alone has failed against 3 different treatment strategies, and the DCB is effective for lesions greater than 10 centimeters, but more data is needed for the Tasaka 3, and of course the cost effectiveness of such lesions. Laser atherectomy is effective for long lesions and is FDA approved, but combination therapy still needs further investigation. Thank you.